All right, good evening, everyone, and thank you so much for joining us for tonight's event with Dr. Ben Gaddie, and he's going to go over blepharitis, the biggest unmet need in eye care. I'm your host tonight. My name is Dr. Ariel Sorenzi. And a big thank you to Avanova for exhibiting at this event. We will get to hear from them at the end of this presentation, and they do have a special treat for all of the attendees. So this will be worth 1 hour of CE credit, so please be sure to attend for a minimum of 50 minutes. For the COPE certificate, please fill out the survey link that is in the chat. It's there, it'll be there now or shortly, and then we'll also be there when the webinar ends. CE certificates will be emailed via email and sent to ARBO with your OE tracker numbers, and you should expect to receive those within about 4 weeks. We will answer all questions at the end of the presentation, so you can put those either in the Q&A section or the chat circled at the bottom. And then if you're on a mobile device, you can find the Q&A at the top or the chat under the 3 dots under the More section. So I'm super excited to introduce our speaker for tonight, Dr. Ben Gaddie. So he earned his doctorate of optometry from UAB and then completed a residency and then continued on for a second year and got his fellowship in ocular disease through Northeastern State University College of Optometry at the Triad Medical Clinic and Cataract Institute in Tulsa, Oklahoma. So after doing all of the amazing things that he could do there with that expanded scope of practice, he brought that over to Kentucky and advocated for them to have the scope of practice that they do now, which is amazing. He's the owner and director of Gaddie Eye Centers, a multi-location full-service practice in Louisville that was started by his father over 40 years ago. He is also a co-founder and chief medical officer of Kepler Vision. He is a fellow of the American Academy of Optometry and a past president and past executive vice president of the Optometric Glaucoma Society. He has published extensively in ophthalmic literature and is on the editorial boards of Review of Optometry, Optometric Management, Primary Care Optometry News, and Optometry Times. He was inducted into the Oklahoma Pioneers in Optometry Hall of Fame. And in 2015, he was selected as one of the most influential doctors in the last 50 years by the industry publication Optometric Management and was awarded the Kentucky Optometric Association Optometrist of the Year. So he's in Louisville, Kentucky. And I think he said if you guys need a place to stay for the Kentucky Derby, he's just offering up his house, right?
That's right. That and bourbon tours,
Bourbon tours. So here are his financial disclosures, all of which have been mitigated. So I will have you go ahead and take it away from here. Thank you so much for joining us tonight.
And thank you, Dr. Sorenzi, and add my welcome to everyone out there in virtual world. And you may have seen the title of this talk and thought, yeah, I mean, how could this be the biggest unmet need in eye care? And I think hopefully by the end of this talk, you'll understand the burden that we see in the United States. The prevalence is quite high, and we really have had no good treatments for a long time. So when I say that we'll talk about ocular surface disease, I know the theme of Dr. Wu's segment here is on dry eye and blepharitis and Demodex and things of that nature, but they all go together. Like, they don't live in a vacuum. I hear people say, well, only treat MGD because that's the cause of dry eye. Or I only use, topical anti-inflammatories because I think it's inflammatory. Well, it's like a three-legged stool. There's inflammation, there's meibomian gland dysfunction, and there's blepharitis. And I think those three things, really, if you could solve for all three of them, we would really help our patients in this ocular surface disease journey. And I frequently have patients where I've had them on the best, whether it's a Cequa or a Xiidra or a steroid or whatever it is, and they're doing a lot better, but they're not over the hump. Like, if you actually do a speed survey, and I do this on every patient I see, which is a verified, validated symptom score for dry eye, you'll see that maybe they started at an 18 or a 20 out of 28, and they go on one of those therapies and they get down to around 12 or 10, which is a huge reduction, but they're still not over the hump. And it's because we haven't addressed one of the other causes or contributors to dry eye. So with that, I submit to you that, we've been missing this blepharitis game all along. And again, it doesn't live in a vacuum. So what is blepharitis? When I was in optometry school in the late 90s, we were taught that you either had anterior or posterior blepharitis, and posterior blepharitis was really poorly understood. That was about the time we were starting to learn that posterior really meant meibomian gland dysfunction, and it wasn't like some different type of blepharitis. It was an actual meibomian gland, glandular dysfunction. And we thought that anterior blepharitis was really just caused by bacterial overgrowth. And I'm sure many of you hold that notion or held that notion, and that staph endotoxin and things of that nature is what caused the corneal effects that you see around the limbus that we always associate with bacterial blepharitis. But I'll tell you that I don't think bacterial blepharitis is really a predominant feature whatsoever. We have staph bacteria all over our body. I mean, if you were to sample and try and grow out any type of bacteria on your body, you would see staph virtually on every square inch of your body, and that includes the eyelid. So I think we were a little misled there. And then we got to the TFOS, the Tear Film Ocular Society, the DEWS, all these sophisticated publications of the world's best scientists and clinicians, and I think they agree with me. So this is from the MGD workshop, and this was probably 30 investigators and experts tried to come to consensus on what is MGD. And basically they said it was a chronic diffuse abnormality of the glands characterized by terminal duct obstruction, that meaning that the ducts of which the meibum is excreted are obstructed, either scarred or keratinized. And then that which does come out, it has a quantitative or qualitative change that makes it not good. And this results in all the symptoms we think of dry eye, right? So that's what TFOS said, or the MGD workshop. And then you see TFOS DEWS 2, and you see all these different categories, right? And so they talk about blepharitis here. Anterior blepharitis, eyelid features such as anterior blepharitis and Demodex blepharitis, or differential diagnosis and comorbidities. So even here, they start to recognize that anterior blepharitis really is more than just an allergic reaction to external agents such as staph endotoxin, that there's truly more to it. So they put a whole section on Demodex, and we won't talk about everything they say about it, but basically our most prestigious publications on ocular surface disease see the importance of Demodex. So what? People have Demodex and blepharitis, and you notice I'm kind of using them interchangeably. And the reason is that I think they are interchangeable. And, I've had the opportunity, I'm the lead author on one of the publications for a new medication for blepharitis. And one of the things we noticed is that all forms of blepharitis just kind of went away, meaning I'm not sure that there are different variations really of blepharitis. I think they all have a common denominator of Demodex as well. But we know Demodex is also really common around the face and in adnexa. For example, it's a common cause of acne rosacea. We use all types of treatments today to treat ocular aspects of acne rosacea, including IPL laser, off-label oral antibiotics. You think about seborrheic dermatitis. Seborrheic dermatitis is a sebaceous gland disorder in which you produce more oil than you should. Well, guess what? That is involved with hypersecretion of glands, somewhat like we see with seborrheic blepharitis, which also has characteristics of Demodex as well. So is Demodex an etiological factor in seborrheic dermatitis? And as you can see, if you want to read this entire paper, significantly higher in those patients. Allergy, been linked to different immune reactions on the skin and on the ocular surface. And then when you look at rosacea, rosacea patients 7 to 8 times more likely to have Demodex, not only on the eye, but in the glands in the face, in the oil glands in the face. And you can see this patient, female with both ocular and facial rosacea, and you see the pustular component on the cheeks, and then you see the characteristic Demodex collarettes. Demodex also associated with floppy eyelid syndrome. And floppy eyelid syndrome, you can see this individual has the pustules on the nose. So, there's rosacea, there's all these common threads that the more you think about it, the easier it is to put together. And it's, again, not just the follicles in the eyelashes, it's the follicles in the eyebrows, the little tiny hairs that you can't really see except on the slit lamp. When you're using your slit lamp under high mag, sometimes if you get off of the eye itself and get just right here in the corner, you can see little hair follicles. I see Demodex in those all the time, probably in our nose hairs, probably in our ear hair, which of course you get more of as you get older. And so these all play into this category of blepharitis. When you look at the blepharitis, the MGD workshop from the International TFOS syndrome publication, you'll notice that the secondary causes of obstructive MGD include seborrheic dermatitis, acne rosacea, psoriatic disease, the hypersecretory form of MGD, seborrheic dermatitis, acne rosacea. So I've tried here in the first few minutes to really make a story or make a case for the fact that this isn't just a eyelid disease or a eyelash disease. This is a dermatological phenomenon, and one that's associated with many common dermatological maladies, as well as, I think, one of the 3 legs of the stool of ocular surface disease. So when I was in school, and I took this picture of myself probably in 1997 or 8 during my training, this is what we thought of anterior blepharitis. This is an older individual. You can see a lot of the lashes are broken off, and there are these little encasements or collarettes, cylindrical dandruff, or some of the names, scurv. There's all sorts of different nomenclature. We actually formed, I'll show you the paper in just a minute, a task force, an expert task force amongst ophthalmology and optometry to see if we could get consensus on what we call this stuff, basically. And cylindrical dandruff seems to be the highest consensus term for this. I think it really encompasses what you see, right? You see this translucent cuff around the base of the lash. And, once you see this and you begin to see it routinely on every patient that you see, basically, it becomes very, very easy to diagnose. Here's another patient with what I would think of as traditional anterior blepharitis, just kind of that flaky material on the lashes. Not so much, we have a couple encased lashes here, but not what we saw here, where every single lash had cylindrical dandruff. This one, maybe just a couple, but just any of this junk that you see on the lashes, this probably has a Demodex etiology. Here's a elderly patient with end-stage blepharitis, MGD. You can see the meibomian glands are displaced almost down nearly to the lash line. And you see really keratinized areas of the lash line, Demodex. This is a patient that's probably suffered for a long time, but no doubt of the etiology. So here's a patient with seborrheic blepharitis, and seborrheic blepharitis, again, is usually in a mixed form, meaning there's this yellow chunky material that you're seeing along the base of the lashes. That is seborrheic. That is the yellow oils coming out of the seborrheic glands, not the meibomian glands, but this is coming off the skin. And when you photograph this, you can kind of see the oily sheen on the surface of the lid. We also see this again mixed with other forms of blepharitis. Here's a patient with, you can see to the temporal side of the lid, really a big, huge, almost a honeybee nest of collarette. And as you move down, you can see a lot of the lashes are just coated, not only with Demodex collarettes, but also with this yellow, flaky material that I'll point out right in this area. You could almost lift that up, a lid scrub or some type of hypochlorous acid, something like that would do wonders to get this stuff off of the lid. But it is mixed disease. And then if you go up and you look at the meibomian glands, you'll notice that there's a lot of telangiectasia, there's pointing of the glands. So again, I'm sorry, I've lost my mouse here. Try to get fancy and draw. Oh boy. Okay, there we go. I apologize, guys. All right, so here is another example of seborrheic material around the lashes. Some of this just gets stuck in the lashes. It's not necessarily coming from directly from the meibomian glands, just getting stuck in the lashes. So rosacea, what is it characterized by? Erythema, telangiectasia, pustules, prominent sebaceous glands. So acne rosacea and seborrheic dermatitis really go together, as well as the rhinophoma. So I have a circle there on my slide. I don't know why it didn't go away, but I was trying to annotate something. So we'll stick with that for just a minute. This is a look at the telangiectasia across the lid margin. You can see these little tiny fine vessels. The way that I can tell if they're normal vasculature, like these vessels right below by the lash line, they're a bigger gauge, they're larger vessels, but as you get to the lid margin, they're really fine in telangiectasia. But if you look down at this picture, I took this picture for a ocular rosacea talk I was doing. But if you look down where the eyelashes are, you can actually see on one of these lashes, there's a full Demodex hanging off of the lash. And then there's many other lash follicles that you can see some kind of granulation to, and just a little bit of encasement or sleeve around those lashes. So what do we know? We know that blepharitis and MGD are extremely common. We know that Demodex is extremely common, and that lid disease is a common factor in evaporative dry eye. We know rosacea is a common cause of MGD, and Demodex is a common cause of rosacea. So all these things that we thought were anterior blepharitis or bacterial staph blepharitis is probably Demodex. So what we haven't known traditionally is what the true prevalence of Demodex is. So how many of our patients in the US have it? And this is a question that I still think needs to be answered, and I don't think it's been sufficiently answered for me, and that is how much Demodex results in actual symptoms. So if you have a full lid full of Demodex, does that mean you're going to be symptomatic? If you just have one eyelash that has a cylindrical dandruff, does that mean that you're going to be symptomatic? If you're not symptomatic, should you treat it? Like, these are all questions that I think we'll have to grapple with clinically. So what we really don't know is there a socioeconomic predisposition to Demodex? This is another question that has been recently answered. We see this in all socioeconomic classes. There's no patient type that gets this or doesn't get it. We see it in literally all ethnicities, of course, genders. Is there an autoimmune type of predisposition to blepharitis? And when you see the actual prevalence, you'll understand that there's probably not an autoimmune contributor. And how long have we known about this? The Handbook of Entomology, Cornell University, back in 1915, these professors identified and really did the whole entomology on the mite itself. You can see they have 4 palpal claws on each side, and they're used for locomotion. But they also have these little needles basically that come out of the claws that can pierce the cytoplasm of cells, and that's how they feed. So they go through and they kind of mechanically are piercing as they go, trying to suck whatever kind of oil or nutrients they can out of the lid or the skin or the meibum. And they have a mouth, but they really don't have a digestive exit in their system. So eventually, as they go through their life cycle, which is actually quite short, they end up, for lack of a better term, exploding, and the carcass of which you see getting pushed out of the follicle and onto the lash line, and that's when you see that cylindrical dandruff itself. Here's an electron microscope view of a Demodex, and you can see those little sharp piercing needles on the end of the claws. So you can see the mouth and the long tail. There are different sexes, by the way, of these. There's male and female. You can see under microscopy, you can see the genitalia of them. If you actually pull a lash and look and put it under high mag. So before I get too far into this, I do want to make sure that I'm very clear about this. You do not need a microscope, or you do not need to pull any eyelashes to diagnose Demodex. If you see that dandruff, that cylindrical cuff dandruff around the eyelid, that is Demodex blepharitis, okay? You do not need to go through this whole routine. And I actually have quite a bit of a story around epilating eyelashes. So for years, I would say starting 2009 or 10, when I really started to get into this, I bought a microscope, and it has a little screen on it, a little LED screen, and you pull a lash and you fixate it on the slide and you put it under the microscope. And once I finally found a lash that looked like the one up in the upper left here, you see the eyelash is the long object, and then all these little bugs. As you get towards the left side of the slide, you see this translucent area. That's part of the whole apparatus. But the first time I saw one, I couldn't wait to race into the room and show the patient. And I said, Miss Jones, here you go. This is your problem. Look, you have these bugs and they're in your eyelids. And she absolutely lost her mind. I remember she was screaming, like hysterical. And I learned through time that you have to be sensitive about how you talk to people. I know a lot of my colleagues, both ODs and MDs, that are ready to go in and start talking about this in really, coarse terms. Like, you have bugs, you have mites, I want to show them to you. My experience has been that a softer approach is probably going to keep people from thinking that you're crazy, first of all, and secondly, to get some credibility. I talk about the prevalence of it, which we'll show you the study in just a minute. And I talk about the fact that most people have this. This isn't, I don't need to show them bugs on their body to educate them that they have a condition that's causing them symptoms. By the way, here's the two genders, the female on the left and the male on the right, and you can see the parts there. So the life cycle is really not very long at all. You can see that it starts as an ovum, as kind of a molt, as we call it, and you can see the little eggs or the molts on the eyelashes if you were to pull them, and you don't have to. But if you were to pull a lash, you could see these little molts, and over 60 hours, they turn into a larval stage. Another day and a half, they become a proto-nymph. Another 3 days, they become a nymph, meaning they're almost fully developed. And a couple days later, they are into an adult. And once they're an adult, we think their lifespan may be anywhere from 3 days to 2 weeks. So they're not long for this earth. Here is one in kind of the larval stage. So it's gone from a molt and it's starting to form. You can see that it's not obviously fully developed. So I was lucky to catch this one on a slide. So what about all this? Okay, what are the symptoms? Well, the symptoms will not surprise you. They're very, very similar to what we see with ocular surface disease. Sorry, I want to go back. Okay, so what are the main ones that I see? Eyelid itching. And this is one when your patients come in and they talk about, my eyelids itch. or excuse me, when they talk about their eyes itch. This time of year in Kentucky, we have like horrible allergies. So everyone complains about itchy eyes. I think it's really important to ask the patient where their eyes are itching. And that may seem like a strange question to ask, but I always say, show me where they're itching. And they'll do one of two things. They'll either take their finger and go horizontal across their lid. I mean, it's almost like a visceral response. They just start scratching across their eyelid horizontally, or they go in with their finger right into the conjunctiva and start grinding, like really want to grind because it itches so bad. The grinding, I think, is pathognomonic for allergic conjunctivitis. And I think when they reach up and do this, that is just telltale for blepharitis and Demodex blepharitis. So facial itching is another one. You see people that may scratch their face a lot. But the other thing we really see are red eyelids. And I want you to think about the market that Lumify, for example, has over the counter with bromonidine to be able to whiten the eyes. So white eyes are a really big business worldwide, and especially here in America. So I think that what we overlook as both patients and consumers and as doctors is that red eyes are not always a red conjunctiva. Many times it's a red eyelid. And that's something when you're standing, 5 feet away from someone, you can't really differentiate, I don't think, between a really red eye and just a swollen, thickened red eyelid. So that is a big characteristic of Demodex, and one in which I think can be treated. I think one of the most telltale signs of Demodex is watering. Like your patients that complain about constant eye watering. At least, if I see 25 patients a day, at least 4 or 5 explicitly complain about their eyes watering. Now, there's a lot of causes. It could be nasolacrimal problems. It could be, frankly, just dry eye. But a lot of the times it's related to Demodex. Of course, eyelash loss wouldn't be surprising. I was having dinner with my wife tonight, and we were talking about one of her friends. She told one of her friends that I do a lot of work with the eyelid mites, and her friend freaked out and said, well, I use a PGA on my eyelids to grow lashes. And I was trying to explain to her that the reason that people seek out eyelash extensions, eyelash growth serums, etc., is because they probably have Demodex that is causing the lash loss. So I hear a lot of people say, gosh, every person that I examine that have eyelash extensions have Demodex. And I just sit back and think to myself, well, duh. I mean, it's like a cycle. So eyelash loss is a big one. Discoloration, brittleness of eyelashes, and then distension of the actual follicle itself, I think, is a very common feature, and which ultimately leads to the loss of the lash. One of the things that while we're talking about chronic watering that I'd like to point out is this conjunctival chalasis, or redundant conjunctival folds. Here's a patient in primary gaze at the slit lamp, and you can see the, almost looks like a membrane with some vascularization in it up against the cornea. Well, guess what? If this was sitting up against your cornea, your eye would water. And that's what we see with conjunctival chalasis. So here's a picture of the patient in primary gaze, and then I asked the patient to look up in the picture to the right, and you can see it's almost invisible. It doesn't exist. So this is one of the other more obscure but not so uncommon causes of eye watering. Here's another example of a patient with just this billowing conjunctiva. All right, so slit lamp examination. Cylindrical dandruff is and will always be pathognomonic for the presence of Demodex infestation. So what does it look like? I've already showed you a few cases, a few examples, but here's some where you can kind of just see the lash distended through the opening or the orifice of the Demodex collarette. So in clinical trials, 100% of people that had a collarette when their lash was epilated had mites. But not everyone with a mite will necessarily show a collarette, at least when you examine them. So again, When you have a collarette, 100% chance you have a mite. When you have a mite, there's not a 100% chance you'll have a collarette. So if you see someone with symptoms and you don't see a collarette, that doesn't mean that they don't have Demodex blepharitis. And I'll show you a technique that you can use to kind of check for that. Here's another example, really obvious. Looks like beeswax sitting on the lashes. Here's another one, just having the patient look down. So this is a key component of your diagnostic pathway, is that you have to change your behavior. And I want to tell you that I've worked with a lot of doctors. I work with almost 700 plus doctors right now in my organization. And to change behavior, to change what I do, in my clinical examination process, if you said, hey, I want you to start doing this differently tomorrow in your routine, it's really hard to do. It's like saying, I want you to you go to the same office, you leave your house every day, and you drive to your clinic. And there's a way that you go almost every time, unless there's an accident. But what if I told you I want you to start going a different way? How long would it take you to remember that you're supposed to go that other way? Well, it'd be almost impossible to change. And so this concept of asking doctors to look for collarettes is a challenge, but it's one that I think is super rewarding. And it may be the easiest of all changes you've ever made in your clinical practice. What I do is there's a lot of variations of this, but you want your patient to look down ultimately. And the way that I do my regular slit lamp exam. And then before I finish, I say, now I want you to look down. And almost every patient knows exactly what to do. They just gently close their eyes, they look down. And when you look at just your normal magnification, even turn it up one click if you need to, when they're looking down and you look like this, and this is your view, if you can't see that, then you're not looking, is what I would say. Here's another example, a patient looking down. It happens on both the upper and lower lids, by the way. So it's not just on the superior, but it's easier to see in total when you have the patient look down on the superior lid. And there's that picture I showed you there at the beginning. So Milton Hom and Kathy Mastroda, two excellent optometrists in our profession, published this paper in our Academy journal, probably 7 or 8 years ago now. But basically, this is showing a patient that we suspect Demodex, but they don't have a collarette visible. Like, I don't see a single evidence of any collarette anywhere. So what they do is they do this technique where you take a pair of cilia forceps and you grab the lash. You don't want to pull it out. You don't want to epilate it, but you just want to pull it taut, if that makes sense. And once you do, then you take it and you just, with a little bit of light pressure on the lash, you're going to circular grind, almost like a medicine ball phenomenon. You're just going to do this little circular grinding without pulling out the lash, but keeping it tight. And what you'll see sometimes is after you do that, you squeeze out a couple of the dead carcass of Demodex. And some of those could even be live Demodex there. Those look pretty translucent. So it wouldn't surprise me if that was an actual grouping of Demodex themselves. Here's a patient where you can tell we've treated them with tea tree oil. So I know we're going to get into this in just a minute, but you can see how irritated the eyelid is around this eyelash follicle, really flaky atopic dermatitis appearance. But we just circular ground this one, and you can see a bunch of good stuff coming out of there as well. So again, here's my microscope sitting on my desk, not real fancy. This is one of the first ones I hit on. You can see I have 2, 4, 5 at least visible. Here's one hanging like a bat off of a lash. And here we have several groupings towards the left side of the slide. But if you look along the lash as you follow it towards the right side, you'll see these little hairy looking things. Those are the eggs or the molts. And here's another picture of those from a higher magnification advanced microscopy technique. Here's an example of the distension. You see these gaping kind of orifices from the eyelashes. Here's a patient with pretty severe Demodex. You see this granular kind of ground glass appearance around each follicle. Those are, little Demodex coming out. You also see a hordeolum. on this eyelid, and it's not surprising. We talked about things that Demodex blepharitis can cause, but one of the main ones by far and away is hordeolum and chalazion. So whenever I see someone with that and they say, oh, I keep getting these, I keep getting them no matter what I do, it's Demodex. Okay. So when we have a good effective treatment for it, I think we'll be able to cut down on that prevalence. But I point out on the bottom right part of the slide, you see this kind of Lone Ranger eyelash sticking out. And if you look off the end of it, you can see a little tiny Demodex just kind of hanging off that little lash itself. So pretty good picture. And there I took the lash and did it in higher magnification at the slit lamp. So that's about as good as I've ever been able to do with an individual lash. So as you can imagine, there's a lot of controversy around this. First of all, there's a lot of disbelief. Like, is this really a phenomenon? Is this, I thought Demodex were like, lice or some type of, STD related mite on the eyelid. They're not easy to see. And at the same time, they are easy to see because you can actually visualize the collarettes, which are the carcasses of the Demodex. So I don't know what else you need other than dead Demodex to prove it to you. So this paper just got published last week, actually, and I wanted to just kind of put it up here and share it with you. This got published in Nature, sponsored by the Royal College of Ophthalmologists, and you can see some of the names on here. Besides me and except me, some of the biggest hitters in all of Eyecare. And we had this really cool Delphi panel experience where we met virtually, we did surveys, we met live, and we tried to come to consensus about Demodex, like what it means. And we did come up with some nice illustrations and drawings. You can see the mites up into the lash follicle and figure B, figure C. You can see around the meibomian glands. This is something we haven't really talked about yet, is that Demodex, they like oil and they also like the meibomian glands. So there is a lot of interest in the role that Demodex plays in MGD. And as I told you, these things are all related. They don't live in a vacuum. So be expecting to hear more and more about Demodex actually infiltrating the meibomian glands themselves. All right, and these are the areas of kind of consensus we talked about. Collarettes are pathogenomic. I mean, we all agreed on that. Epilation is not necessary. We all agreed. And we agreed that if you were to epilate, the more mites you have, the greater this density and severity of the collarettes. So you can see all the different measures we talked about, but one of the things that we really couldn't agree on is the trigger to treat. Like, how much Demodex do we need to treat? Do we rely on symptoms? Should we be proactive so they don't end up with lash loss and recurrent hordeolum? So let's look at a couple of studies that have been done. I participated in a couple of these studies over the last few years. We think that the marketplace, the number of people in the US that has Demodex, approaches 25 million. And what we know from a variety of studies is that Blepharitis is routine. We'll talk about the prevalence. Blepharitis can lead to a whole host of other diseases and corneal diseases. And it can impact the outcomes of cataract surgery, refractive surgery. I know you've heard that to death. But the one that's really important that I think we should be thinking about in our clinical patients are contact lens patients. 51% of patients in a prevalence study that we did that wore contact lenses had Demodex. So over half of your contact lens wearing patients, and think about how many of your patients drop out of contact lens wear each year because of discomfort, vision, fluctuating vision. Again, these are all related. So the Titan study, which I was involved with, looked at 1,000 patients. So in our clinic, we took 150 of the first comer patients. So this means that anyone that's walking in the door to see me, it could be for a glaucoma evaluation, a contact lens check, a cataract post-op, just a regular eye exam, whatever it was, we would mark the presence or absence of collarettes. And then we would determine if they were on a dry eye medicine already, okay? And what we found was that overall, 58% of all people walking into an eye doctor's office, OD or MD, have Demodex. Okay, so that's over half and approaching 2/3 of all your patients have Demodex. I mean, tell me another condition that 60% of your patients have. I mean, it's truly unbelievable. And of those, 58% already had a dry eye diagnosis and were on a dry eye medication, whether that was cyclosporin, lifitegrast, or some type of steroid. And when you look at other types of patient groups in the study, 70% already had a diagnosis of blepharitis, but they were on just, common lid scrubs. And if you look at, again, 51% of contact lens patients, 56% of cataract patients. And the other thing we found is it's not just, we think of this condition of being an old person's disease, right? The older you get, the more likely you are in increasing the prevalence of Demodex. But actually, it's in all age groups. We saw it from 8 and 10-year-olds all the way up to, I saw 90 and 95-year-olds that did not have collarettes. So anyhow, the Atlas study was a follow-up study that we did, and what we saw is that 80% of patients that have Demodex had a negative impact on their daily life, difficulty driving at night, putting on makeup. Imagine if your eyes are watering all the time and you're trying to put makeup on. And why do maybe some people want to use a lot of eye makeup? Because their eyelids are red, their eyes are red, they look like hell. And they're trying to, cover that up. Unfortunately, a lot of that makeup, therefore, ends up on the ocular surface as well. So looking at the pathogenomics of this, as I said, 100% of patients that have a mite, that have a collarette have mites. So you can see greater than one collarette, 100% of patients. Patients that had no collarettes that were using lid scrubs, 50%. Had Demodex, and patients with no collarettes and no lid scrubs, only 7% of those did. Getting to the diagnosis one more time real quickly, this is an example from Liz Yu of a patient looking straight ahead, right? I can't see any Demodex, I can't see any collarettes, anything. But then when we have the patient look down, all of a sudden you see fluorid. So what scale is this? So there's a new drug coming out. I'm sure it's no surprise by now, by Tarsus. They are awaiting their final approval, which should be in August. And what they had to do no one's ever had a drug for blepharitis, right? There's never been anything FDA approved prescription-wise for blepharitis. So they had to develop this grading scale. And the eye on the right, if you look at that lid, that's a grade 4. That means that greater than 50% or greater than 50 lashes have Demodex. So the new treatment that's going to be coming out, and this is a CE lecture, so I can talk about new drugs, is called lotilaner. And this is a drug that was used in veterinary medicine for mange, among other things. And what it does is it's a non-competitive antagonist of the GABA chloride channels in insects. So it has no effect on humans, it has no toxicity on human cells, and it causes rapid death. And one of the problems we've had with traditional treatments with Demodex is that nothing can kill the mites effectively enough to interrupt the cycle, their life cycle, their breeding cycle of how they reproduce. And so for the first time, to be able to rapidly kill the mites is allowing for this condition to begin to be, I don't want to say eradicated, but what the FDA is considering cured. So the new drug is an eye drop. It's twice a day for 6 weeks. There's no rubbing. There's no lid scrubs that have to be used, although you could. And after 6 weeks, the data is pretty good. So these are all the clinical trials that have been completed in the FDA approval process for this drug. You can see the 2 phase 3, Saturn 1 and Saturn 2. Saturn 2 is complete. I am the lead author on that trial. And we have submitted and hope to be getting final approval of publication to the American Journal of Ophthalmology, AJO, here in the next few weeks. But the FDA has accepted both of these clinical trials. And so you can see over 800 patients have been treated versus placebo. So the efficacy scores here, you can see are pretty impressive when you look at p-values for clinical trials. Their primary endpoint was what they call complete collarette cure. And that means that there are 0 collarettes. All right. So in the average starting was a grade 3. So, very heavy Demodex load. And so after 6 weeks, you had to completely cure. And that means get rid of everything. And they met that primary endpoint, and you see the p-value. And then they had what they call clinically meaningful collarette cure. And that means that you have no collarettes or 1 or 2 potentially, and that's a grade 1 left. And you can see that looking at mite eradication, they met that. And what was really impressive was the lid redness score. So we'll talk about that in just a minute, but this is a grading scale. You can see grade 4, almost every lash, grade 3, 1/3 to 2/3 of lashes are affected, and that's between the right and left eye. You can see grade 2 is 10 collarettes, grade 1, 3 to 10 collarettes, and grade 0 is 0 to 2 collarettes. This is looking at lid redness, and this is really something that took a while to sink in for me, is looking at this grading scale, and it's 0 all the way to 3 is severe. The average was around 1.5 at baseline. And what they found was that a lot of patients got significant, at least a 1 grade reduction in hyperemia of the eyelid as a result of the treatment. So looking at quickly at the results of this is Saturn 1. Saturn 2 is obviously very similar, as they had to be identical trials, but you can see that 81% of patients had grade 0 or 1 collarette. So 8 out of 10 patients that completely cleared their lids. Looking at by week 2, this is a complete collarette cure. This means grade 0. So they went from grade 3 to grade 0, around 43%. So it doesn't look quite as impressive to completely eradicate every single one, but compared to placebo, it is pretty impressive. The other thing that is interesting is how quickly it works. You see by day 8 and certainly by day 15, you're getting statistical significance. So within 2 weeks, you could potentially treat blepharitis and figure out to what degree this is impacting their symptoms with ocular surface disease. Looking at mite eradication, 68 or over 2/3 of patients had complete mite eradication at week 6. And just a second here, this is looking at erythema. So patients that went from grade 1.5 to grade 0, no hyperemia, about 20%. Had complete clearing of the lid redness, and grade 1 or more improvement, nearly half. In terms of adverse events, you can see pretty low. Burning and stinging was the only thing over 3% or over even 1%. So with that, the thing that I want everyone to start to take home from this talk today is to look down, okay? So here's all examples of patients looking straight ahead, right? And you can see in each of these patients, they have some corneal impacts, right? The patient on the left looks like, some type of vascularized, is that pannus? Is it neovascularization? Is it just some scarring? On the patient in the middle, you see a lot of corneal haze that extends beyond what you would expect from an arcus. And then on the patient on the right, you see outright corneal haze, corneal scarring. And when you ask each of these patients to look down, look what their lids look like, right? These patients are probably already on every type of topical therapy for anti-inflammatory, et cetera. But the problem is we've done nothing to treat these eyelids. All right, so what have we had so far in my last couple of minutes here? Well, one of the mainstays has been tea tree oil, right? And it started with Clearadex. Schaefer Singh down at Bascom Palmer did, really a ton of the work that led to this being an actual full-fledged field of Demodex. And he developed Clearadex. And, tea tree oil is sufficient to kill Demodex mites, but it cannot be delivered in a manner that is effective enough to completely eradicate or interfere with the life cycle. So although we probably all use tea tree oil, and I don't care which one you want to use, Ocusoft, Clearadex, Blepharitis, Zocular, Zest, there's a gazillion of them out there. Optase has some. I have a whole cabinet full of different tea tree oil containing preparations. You also have traditional lid scrubs, and you have hypochlorous acid. And hypochlorous acid has been very popular in ocular surface disease. And I think if you can get rid of the cause of the Demodex, there would probably not be anything better than hypochlorous acid to help maintain the surface of the lids and help prevent recurrence. But what we know from the clinical trials of even the latest drug is that we're never going to completely cure and eradicate this for most patients. We may eradicate it for a year, maybe for 2 years, and then it's going to recur. And we're going to have to treat. Some patients we may have to treat twice a year. Some patients may need every 2 years. But this is a condition that will always be with us. But I'm really excited to see, as we begin to treat all these patients, begin to get resolution finally, how many of them was this their main condition? Not inflammatory dry eye, maybe not MGD, but it was just their eyelids. And what I love is that we're going to be able to have something you can use for a couple of weeks and begin to find out, is it having an effect or not?